Hi, this is Brian Kim. I want to share with you case number 138 in the Best Way to Do Cataract Surgery series. This is a 1 to 2 plus dense lens and a small pupil. You're going to see double chop, cross chop mechanical fracturing techniques and how I'm able to hook lens pieces up instead of trying to grab pieces that are in the bag with high vacuum, which can be dangerous. I'm able to easily just prolapse the pieces up by hooking the lens at the equatorial side. And that's the thing that people get really nervous about. To me, if you really want to stretch yourself and really make yourself a very versatile surgeon, you have to learn how to place the chopper at the equatorial plane. By doing so, you're able to hook the lens pieces up and really leverage that technique and that maneuver to your advantage. So this is a corneal marker, which will help me to center and size the rexus. This is my paracentesis incision, first on the right side and then the left side, making sure the blade is flat to the iris plane, which creates a nice corneal shelf and allows me to achieve a self-sealing incision. This is intracameral lidocaine and then some intracameral epinephrine. You can see the pupil is still rather small. And this is some dispersive viscoelastic to coat the corneal endothelium and to flatten the anterior capsule. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea. Once I achieve the appropriate length of the incision, I enter. You can see this patient's moving their eye a little bit, so I'm using the cannula with a non-grabbing technique, just to cannula through the incision. I go ahead and hold the eye still. I'm able to puncture with the forceps, pull towards me, creating a flap, grabbing the right side of the tear, going around circumferentially, again, using the cannula just to control the eye. Again, rather than grabbing with forceps, rather than using a Thornton ring, that can cause, subconch hemorrhage. The patient moves. They can feel that sometimes. You can even create a corneal abrasion if the patient inadvertently moves towards you. And so, to me, this is the most elegant way, kind of a non-grabbing way of fixating the eye. This is the capsular fornix hydrodissection technique. I place the cannula under the rexus edge contra-incisionally. Trying to separate the anterior capsule from the lens on the left side. And then I'm able to carefully spin the lens, hooking the peripheral lens on the right side. Irrigating the surface of the eye, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, placing the chopper under the rexus edge contra-incisionally, the phaco tip vertically, sub-incisionally, bringing the instruments together towards the center and fracturing the lens in half, placing the chopper under the right heminucleus, pulling it centrally toward the phaco tip, and then fracturing the right heminucleus in half. That is the cross chop maneuver. And people are thinking, aren't you going to grab the capsule when you do that? I'm pushing down on the lens a little bit as I do that. And remember, the epinucleus is soft. And so it's like pushing down against cream cheese or something. It gives. And so I'm able to push down on that epinuclear material, and I'm able to be confident that I'm underneath the rexus edge when I go out to the equator. So I'm using the chopper as well to retract the pupillary edge and protect the pupillary edge as I'm trying to grab these pieces with high vacuum. So I was able to remove essentially that first heminucleus. I placed the chopper around the second heminucleus, pulling it centrally toward the phaco tip, and then bisecting the lens in half, trying to use some vacuum to lift that piece up. It's not coming, placing the chopper around the lens piece, crushing the lens piece in half, and then it loosens the lens piece up, and then I was able to emulsify the lens piece here. Using some vacuum to lift that other piece up, and then crushing the lens piece between the instruments. Doing the same thing here, lifting that lens piece up with some vacuum, and then crushing the lens between the instruments here. And remember, with the small pupils, you just have to keep the phaco tip in the central safe zone if you're going to activate vacuum or ultrasonic energy. You can use the phaco tip as a mechanical fracturing instrument anywhere in the eye, but when it comes to utilizing the ultrasonic energy in vacuum, you want to stay in the central safe zone, because if you use vacuum near the bag, you might rupture the bag or grab the peripheral iris or something like that. So now I believe it's really kind of a challenging view because it's such a small pupil, but now I'm removing the epinuclear material here, and I'm keeping the chopper deep to protect the posterior capsule, and I'm just using foot pedal modulation as I remove the epinucleus here. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. Always start subincisionally, trying to peel the cortex from anterior to posterior. Because the pupil's small, I switch to polish mode fairly early here because I don't want to accidentally grab the iris or the capsular bag as I'm trying to sweep when I'm removing the lens epithelial cells. I polish the posterior capsule here as well. Overall, it looks pretty clean. Because it's a small pupil, I just go ahead and push the cohesive viscoelastic to fill the bag. And when the pupils are small, I just go ahead and put the lens in. I don't really believe in sweeping when it's difficult to see underneath the iris, because all you're going to do is really just sweep the iris in some cases because the pupil is so small. So I'm careful to make sure that the leading edge of the optic and the lens is going into the capsular bag. As the lens unfolds, I go in with irrigation off, activating irrigation. I have the Maltzman in my left hand, making sure that the lens is completely within the bag here, making sure the haptics are both within the bag as well. I go underneath the lens, tilting it, removing all the viscoelastic from within the bag, using the Maltzman to help me do that. Repositing the optic back down, checking the haptics, making sure they're both in the bag, using the Maltzman here. Switching to polish mode, polishing under the rexus edge, and then removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is about a 1 to 2 plus dense lens, and you saw double chop, cross chop, mechanical fracturing techniques, using the chopper to lift pieces up out of the bag, keeping the phaco tip in the central safe zone, and using high vacuum and ultrasonic energy only in the central safe zone. Again, you can use the chopper and the phaco tip both as instruments to hook lens pieces up and to crush lens pieces, and you can do that pretty confidently no matter where you are in the eye. You don't want to ever use ultrasonic energy or vacuum in any place in the eye which can damage the tissue. So not near the iris, not near the posterior capsule. And so that's why I like to use these mechanical fracturing techniques because I have exquisite control of the eye. I'm able to fracture the lens pieces, get around the lens pieces with a chopper, lifting them up out of the bag. I never struggle to get lens pieces up out of the bag by doing it this way. So I hope this was helpful to you, and I thank you for your attention.